Good morning, everyone. Welcome to UCT Virtual Africa ENT meetings. I am Dr. Divya Pallavi Ramyead, an ENT registrar at the University of Cape Town. And today I'll be discussing on a challenging topic that we see very often in the dizzy clinic, vestibular migraine. So let us start off with the case study. A 19-year-old female was referred from a peripheral hospital to the dizzy clinic at Critical Care Hospital. On history taking, she reports of daily episodes of room spinning lasting for 10 to 15 minutes, associated with headache, nausea, vomiting, and a decreased hearing on her right ear. She has a right-sided tinnitus, which is low-pitched, a right-sided ear fullness, and has symptoms of anxiety. She loves sports, particularly basketball, but had to stop sports activity due to the repeated episodes of vertigo. She has a history of motor vehicle accident when she was 6 years old. There is a positive family history of migraine noted, and on drug history, she is on antidepressants and mood stabilizers. We proceeded to do an audiogram, and we noted on the right side, there was a moderate to severe mixed hearing loss. And on the left, there was a moderate sensory neural hearing loss sloping in the high frequencies. We then proceeded to do an ear examination, where she had bilateral normal tympanic membrane. Her cranial nerve examination was normal. Nystagmus and oculomotor function was also normal, with normal saccades and smooth pursuit noted. Her cerebellar function was also normal. Her vestibular ocular reflexes, however, showed on head thrust test a right-sided impairment. There was also impaired dynamic visual acuity as 4 lines were skipped. Her vestibular spinal reflexes were normal, and we came to a provisional diagnosis of vestibular migraine based on the history of migraine or Meniere's disease. We have started her on migraine prophylaxis, and we have counseled her to keep a symptom diary. She is due for colorics in 3 months' time. Now let us have a look how to diagnose vestibular migraine. Vestibular migraine was coined in 1917 and is characterized by episodic symptoms of severe vertigo with or without headaches that can significantly interfere with quality of life. There is a female predominance and a ratio of 5:1. The mean age onset is 37 years for women and 42 years for male. It can, however, come in the first decade till the 7th decade of life. Family history of migraine is found to be noted in most cases. There is also an association with menstrual cycle, Meniere's disease, BPPV, anxiety, and depression. In a study done in the US, 14% of population have migraine. And out of this 14%, 1% is accounted for by vestibular migraine. The pathophysiology of vestibular migraine, just like migraine, remains unknown. There's a theory of a trigeminal vascular reflex, where one can argue if there's cerebral vasodilation or vasoconstriction causes the migraine, and some think it is due to the ion channels in the brain. There is a criteria to define definitive vestibular migraine and probable vestibular migraine, and it is based on Baronese Society and International Headache Society. It should fulfill the following criteria. In criteria A, at least 5 episodes fulfilling criteria C and D should be obtained. Criteria B consists of a recurrent or past history of migraine with or without aura. Criteria C consists of vestibular symptoms of moderate or severe intensity lasting for 5 minutes to 72 hours. Criteria D, at least 50% of these vestibular episodes should be associated with at least one of the 3 migrainous features, which includes headache, which is either unilateral in location, pulsating in quality, moderate or severe in intensity, and aggravated by a routine physical act. There could be reports of photophobia, phonophobia, and visual aura. The last criteria, E, says that it is not better accounted by any other international classification of headache disease or any other vestibular disorder. For probable vestibular migraine, again, there should be 5 episodes of vestibular symptoms of moderate or severe intensity lasting 5 minutes to 72 hours. Here, only one of criteria B and D should be fulfilled, which means either the patient has a migraine history or the patient has migraine features as listed before. Again, it is not better accounted by any other vestibular disorder. Why is this pathology missed and why is it important for us to know it? Commonly in history taking, patients may not report of headache or headache may not be present at the times of vestibular symptoms. Secondly, there could be overlapping symptoms with other causes of episodic vertigo. Thirdly, Meniere's disease, like symptoms of Meniere's disease, which includes fluctuating hearing loss, tinnitus, this can lead to a misdiagnosis. And fourthly, normal neurological examination and neuroimaging can make the diagnosis even more challenging and lead to the patient misdiagnosed as psychogenic. But why does it matter to us to correctly identify such pathology? Vestibular migraine is associated with a lower health-related quality of life. It has been found that 40 to 60% can miss work or school due to these symptoms. 34 to 46% can have an impact on daily activities, and 52% have experienced falls. Most commonly, these patients present to the general practitioner where they're given vestibular suppressants based on the fact they've got vertigo. However, this delays institution of migraine-specific treatment. So how to tackle misdiagnosis is by taking a proper history. In history, we want to know how long does the vertigo last, what are the associated symptoms, is there dysphagia, dysarthria, and paralysis, which will point to a brainstem stroke, is there photophobia, phonophobia, which will alert us to migraine, what is the relation of motion for the dizziness, are there any aggravating and relieving factors? To tackle this, there's a diagnostic questionnaire based on Berenice Society criteria. The 5 questions asked are, question number 1, does the patient have a lifetime diagnosis of migraine according to the International Headache Society criteria? If no, we stop right here. If yes, we proceed to the second question. Have one or more of the following symptoms been experienced at least 5 times lasting for 5 minutes to 72 hours. And this includes spontaneous vertigo, where objects in the room seem to spin, or the patient feels like spinning or turning when stationary. Is there positional vertigo, or is there head motion-induced vertigo? Third question, has one or more of the following symptoms occurred with at least half of the episodes of dizziness? Was there headache? And was it unilateral, pulsating in quality, moderate or severe in intensity, and aggravated by routine physical activity? Was there also photophobia, phonophobia, and visual aura? If yes, we proceed to the 4th question, where we want to see what is the degree of balance symptoms that affects the patient. If it interferes with the patient's daily activities, it is classed as moderate. If it prohibits daily activity, it is severe. If it does not interfere, we can stop right here. If these criteria are met, we go to the 5th and last question, which is hearing loss and ringing in the ears temporarily related to the balance problem? Temporarily related to the balance problem. In such cases, we must consider other pathological disorders. Symptoms experienced by vestibular migraine include lightheadedness, hearing changes, tinnitus, nausea, vomiting, motion sickness, and phonophobia and photophobia. Physical examination shows normal cranial nerve examination, normal cerebellar signs. The vestibular spinal reflexes can be normal, but abnormal at times. Spontaneous nystagmus is rare, and gaze-evoked nystagmus is also rare. On Dix-Hallpike maneuver, one notes that there is no nystagmus, but patients tend to be violently dizzy. There are no specific tests that diagnose vestibular migraine. 50% of patients can have hyperactive calorics. More than 26% can have an abnormal head impulse test. Vestibular evoked myogenic responses show an absent or abnormal ocular vamp, but normal cervical vamp responses. Posterography can be normal to 74%, and pupil audiometry can show sensory neural impairment in only 7.5% of patients. Neuroimaging is normal in vestibular migraine. However, clinicians can opt for an MRI if they suspect posterior circulation stroke or multiple sclerosis. Vestibular migraine often coexists with benign paroxysmal positional vertigo, which lasts, where here the vertigo lasts for 10 to 30 seconds, is provoked by head movements. The Dix-Hallpike maneuver is positive, but what is characteristic in BPPV is the latency of nystagmus, which is a few seconds, and the fast velocity, torsional and fatigable nystagmus observed. One should suspect vestibular migraine in patients who have prominent nausea or vomiting and those that do not respond to the repositioning maneuvers. Meniere's disease also can occur at the same time as vestibular migraine. In Meniere's disease, one notes fluctuating unilateral hearing loss, episodic vertigo, oral fullness, and a low-frequency tinnitus. On the other hand, vestibular migraine, patients feel dizzy all day long and have photophobia, phonophobia, visually induced imbalance, and spatial disorientation. There is a table which shows how to differentiate between vestibular migraine, Meniere's disease, and BPPV. Essentially, vertigo in vestibular migraine will be lasting for minutes to days, in Meniere's disease, minutes to hours, and in BPPV for seconds. There's also a strong history of phonophobia, headache in vestibular migraine, and a strong history of hearing loss and progressive hearing loss in Meniere's disease. One should always think of differential diagnosis in these patients. There could be occult intracranial hypertension, especially in obese females, acute vestibular neuronitis, where one will observe resolution of symptoms after 6 weeks, acute labyrinthitis, multiple sclerosis, brainstem neoplasm, vitamin deficiencies, heavy metal poisoning, and metabolic abnormalities should be excluded. Importantly, transient ischemic attacks should be considered in elderly patients with vascular risk factors, and here a Doppler ultrasound helps to detect the vascular pathology. Vestibular paroxysmia is what is caused by a neurovascular cross-compression of the 8th cranial nerve. Here again, patients present with spinning, but these should fill a criteria where criteria A, it should have 10 attacks of spontaneous spinning or non-spinning vertigo that last less than 1 minute. And these patients respond to carbamazepine. Thirdly, psychiatric dizziness is also a pathology which can confuse us with vestibular migraine. Here in psychiatric dizziness, there is a background history of anxiety and depression, but the dizziness is provoked by a situation which leads to an intense autonomic activation and vertigo. It has been noted that 50% of patients with vestibular migraine have comorbid psychiatric disorders. How to rule out a posterior circulation ischemic stroke is by the red flags, which include the central signs. And to elicit this, we've got a mnemonic, which is HINTS+, which includes head impulse, which is normal, nystagmus, which shows direction changing nystagmus, torsional and vertical nystagmus, and a test of skew, which shows skew deviation in patients with this central pathology. One should also be alerted to a posterior circulation ischemic stroke if there is unilateral deafness, dysarthria, limb weakness, and severe gait ataxia. Now, before coming to the treatment for vestibular migraine, one should understand what are the triggers for migraine. There are different causes for triggering factors: the hormonal factors, emotional factors, which includes anxiety, stress, physical factors, even poor quality of sleep, dietary factors such as alcohol, caffeine, chocolates, citrus fruits, environmental factors, and medicines such as hormone replacement therapy or oral contraceptive pills. Once we've taken what are the triggering factors from history, we can then proceed to a stepwise treatment. In step 1, we will institute a migraine diet with regular daily scheduled meals and stress and anxiety management. Step 2, one can use tricyclic antidepressants and carbonic anhydrase inhibitors. Step 3, beta blockers, calcium channel blockers, flunarizine, and anticonvulsants can be used. And if all this fails, one can opt for a neurological consultation. Broadly, the treatment of vestibular migraine is divided into abortive and preventive treatment. Abortive treatment, very useful, are the triptans. Secondly, if this is not available in your institution, you can always opt for aspirin, non-steroidal NSAIDs such as Brufen, ergotamine, antihistaminics to help with the nausea, vomiting, antiemetics, and benzodiazepines. In preventive management, anti-epileptics such as topiramate has been proved to be useful, as well as beta blockers, calcium channel blockers, antidepressants, and anticonvulsants. Vestibular rehab is also useful in vestibular migraine, and the aim of vestibular rehabilitation is to provide adaptation, habituation, and substitution to facilitate the vestibular compensation. One must note that in vestibular rehabilitation, every individual is different, and while one patient can tolerate an exercise for more than an hour, other patients can tolerate the exercise only for 10 minutes, and hence these are tailor-made exercises to the individual. Novel techniques in vestibular migraine includes external trigeminal nerve stimulation and non-invasive vagal nerve stimulation. And these are approaches that are still being considered. With this, come to the end of my presentation. Thank you for your kind attention. Are there any questions?
Divya, I'll ask you a question. Thank you. A very nice, comprehensive talk. It's not something I deal commonly with. I just wanted to ask you, perhaps Christine could comment if she's on the call. In your case presentation, your primary diagnosis was vestibular migraine. I was wondering why it was not the ears disease.
So it was because there was a strong family history of migraine. The head impulse test was impaired on the right, and there was dynamic visual acuity, which showed 4 skip lines. But it was mostly based on the history that there was episodic spinning lasting for 10 to 15 minutes. The patient had a strong family history of migraine. She herself complained of migraine. Yeah, so that's why. And there was motion-induced vertigo also, because she couldn't play basketball, because every time she played with the ball, that would trigger vertigo. But maybe Dr. Rogers can comment more.
Hi, morning everyone. Sorry, I got my computer suddenly collapsed, but it's back again. Yeah, I think in this case, it was quite an interesting case in terms of that right-sided hearing loss, which would automatically sort of take you down a Meniere's path. And of course, the two conditions can actually coexist as well. However, there's absolutely no fluctuation of that loss. And there is an NVA age 6, which we think was probably responsible for that loss. Or it could have been a congenital loss. So we think that the hearing loss is actually a kind of red herring, and there's a lack of any other sort of auditory symptoms going on, and no history, sensations of fullness or fluctuation, marked tinnitus or anything else. She also, she actually had an episode while she was waiting on the bench to see us, and I walked past her and she looked absolutely terrible, to the point that we were running around getting Stemetil and one thing or another. And by the time we saw her, she'd actually completely recovered, and she was looking much better. So I think that was what was underpinning the right-sided positive head thrust test, because she had just had an episode, and I'm sure that that would have resolved if we'd have seen her further away time-wise from the attack that she just had. And that very, very quick recovery and lack of a sort of post-ictal hangover type feeling afterwards is also very typical more of migraine than Meniere's.
Thank you. Are there any more questions? All right. Thank you for your kind attention. With this, we'll end our meeting. Have a nice day.